So welcome to the Osteoarthritis Action Alliance Lunch and Learn for September 21st, 2016. My name is Kirsten Ambrose, and I wanted to thank you all for joining us. I'm pleased to introduce our presenter, Jackie Whittaker. Dr. Whittaker is an assistant professor in the Department of Physical Therapy at the University of Alberta in Canada, where she is also research director of the Glen Sather Sports Medicine Clinic. She's recognized as a clinical specialist in musculoskeletal physiotherapy by the Canadian Physiotherapy Association and is a fellow of the Canadian Academy of Manipulative Physical Therapists. Through her research, Dr. Whittaker seeks to influence a shift in the approach taken to manage chronic musculoskeletal disorders from treatment of chronic disease or tertiary prevention toward prevention and delaying or halting disease onset, which is more primary and secondary prevention. So today, Dr. Whittaker will speak to us about primary and secondary prevention of pre-radiographic OA. Welcome, Dr. Whittaker.
Perfect. Thanks, Kristen, for that introduction. I just want to ensure that you guys can hear me, yes?
Yes, loud and clear. Thank you.
Perfect. I just didn't want to speak to myself for the next 20 minutes. Okay, well, welcome everybody, and thank you, Kristen, for that introduction and for the invitation to give the talk today. As Kristen's indicated, I am a physiotherapist and a researcher at the University of Alberta, which is located in Edmonton, Canada. And as you can see, I am going to speak to you today about preventing osteoarthritis. So as many of you that are tuned in today probably know, osteoarthritis is the fastest growing disease globally. However, not only is it the fastest growing disease, the disability and the inactivity that results from osteoarthritis really increases the odds of a lot of other diseases. So things like obesity, diabetes, and cardiovascular disease, which in turn then increases the risk of death. So inactivity and disability resulting from chronic musculoskeletal disorders like osteoarthritis are quite a large problem. Now, there's an increasing number of signs that suggest that one of the forces driving this increase in osteoarthritis is an earlier age of onset that stems from a youth sport-related injury. These two examples come from our colleagues in Australia. The first points to a 29% increase in sport-related injuries over a 6-year period prior to 2010 in those under the age of 15, and then the second corresponding 24% increase in those over the age of 15. In Canada, we know that sport is the leading cause of injury requiring medical attention amongst our youth, with approximately 1/3 of those between the ages of 11 and 18 seeking medical attention every year due to a sport and recreational related injury. Knee injuries are the most common. They count for somewhere between 20 to 40% of these injuries. And then we know, based on recent meta-analyses, that approximately 50% of those who experience a significant knee joint injury are going to go on to develop post-traumatic osteoarthritis in about 10 to 15 years. So I suspect, although this data is related to Canada, that it relates as well to the United States of America as well as other countries around the world. And why are we focusing on the knee? Well, the reason we're focusing on the knee is that about 80% of the burden of osteoarthritis is due to knee osteoarthritis. So just to put that into a little bit more of a perspective, and I'm going to continue with the Canadian example because it's obviously near and dear to my heart. In 2015, we had about 3.1 million 11 to 18-year-olds in this country. Knowing that 1/3 of them sought medical attention for a sport and recreational related injury, and let's be conservative and say that only 20% of those injuries involved the knee and were significant knee injuries, what it boils down to was that there was around 94,000 11 to 18-year-olds in this country last year who sustained an injury to their knee while participating in sport that may end up having a diagnosis of post-traumatic osteoarthritis by the age of 33. Now, this is noteworthy for obviously a variety of reasons, but maybe most importantly, because an injury sustained in youth will result in a greater number of years lived with disability than obviously an adult injury. Now, there's a variety of different ways that we could go about trying to address this growing problem of osteoarthritis, and these approaches can be organized using this framework for disease prevention. Primary prevention would refer to strategies aimed at preventing or reducing joint injuries in susceptible populations, so youth that participate in sport and recreation. Secondary prevention refers to strategies that are aimed at either slowing down or halting the onset of osteoarthritis after an injury has occurred. And then tertiary prevention would be strategies that are concerned with improving function and reducing disability in those that actually already have osteoarthritis. Now, as there is no known cure for osteoarthritis, the only way that we can actually reduce the burden of the disease is to move our focus upstream onto primary and secondary prevention strategies. So if we take the timeline of a child from a healthy pre-injury state through knee injury to the point in which they're going to receive a diagnosis of osteoarthritis, and we overlay this framework from the previous slide, we see that there's opportunities for primary, secondary, and tertiary prevention. And as Kristen pointed out, I'm going to really focus on the primary and the secondary pieces for today. So let's start with what we know about primary prevention. The good news is that there has been a fair number of high-quality studies that have evaluated the efficacy of injury prevention programs or interventions in youth sport. Recently, we had an opportunity to synthesize these studies with a systematic review and a meta-analysis to summarize the risk-reducing ability of neuromuscular training programs, specifically as it relates to reducing lower extremity injuries and knee injuries in youth. In this systematic review, we identified 25 studies that met our inclusion criteria, and that included 14 randomized control trials. And they represented a variety of sports, but predominantly, as you can see here, European football, or what most of us probably on the call today would refer to as soccer. The identified prevention programs contain some common components, including sport-specific preseason training, sport-specific warm-ups, programs that consist of some combination of aerobic, dynamic, stretching, and agility components, as well as some strengthening, agility, coordination, and balance training. And then some of the programs included a home program, but others did not. And when we crunched all the numbers and we did our meta-analysis, 8 of the randomized control trials that fit with respect to lower extremity injury revealed that these neuromuscular training injury prevention programs lead to a 36% reduction in lower extremity injury and a 26% reduction in knee injury risk. Now, you might ask which components of these programs have the most effect in reducing injuries. In a recent meta-analysis involving 25 randomized control studies that involved not only youth but also adult populations suggests that the largest preventative effects are seen in programs that incorporate proprioceptive, strengthening, or multimodal type training. Those little triangles are supposed to be check marks, but they're not quite coming up as that. And then programs that involve just stretching alone, that's supposed to be a cross, have not been shown to have any benefit. So the benefit really doesn't seem to be coming from programs that incorporate stretching, but it's really from those that incorporate proprioception, strengthening, and then some kind of a multimodal type of a program. So clearly, injury prevention or primary prevention programs work. So the big question we have is, why are we not seeing a reduction in youth sport injuries? What's going on? I'm going to use this slide to kind of explain that. Basically, what we see in many instances is a lack of program uptake and maintenance following the research studies that have been done. So this is an example from our colleagues in Norway. Just happens to involve European handball. Each bar represents the number of injuries sustained by a group of players over a season. The black bar represents a control season. So this was a season where we just monitored the number of injuries and we didn't do any sort of an intervention. And then the yellow bars represent seasons in which an injury prevention program was introduced and evaluated. And as you'd expect, we saw a reduction in the number of injuries. The first 3 green bars represent the several seasons after the study was completed, the researchers left, and what we see is an incremental increase in the number of injuries. And this is associated with poor maintenance of the prevention program. So basically, the athletes and the coaches stopped doing the program. In fact, it wasn't until we implemented coach seminars focused on injury prevention, as well as an online resource as a method to enhance or to facilitate program maintenance, did we actually see a drop in injury incidents again. So this bar graph highlights very clearly that knowing what to do and actually getting it done are 2 very different things. So the main recommendations regarding primary prevention or injury prevention programs is that we sort of need to get on with it. We know that they work, but what we've got to do is focus our efforts on continuing to figure out how to implement these programs in real world contexts so that ultimately coaches and players will maintain using these programs, and this will result in a greater public health impact. So that's sort of the state of the union with respect to primary prevention. Basically, there's been a lot of work done. We know the programs work, and we have a really clear direction as to where we need to go now and focus, and that's namely implementation science. So what about secondary prevention? Well, this is a little bit more interesting. In general, we have a fairly poor understanding of the period between joint injury and osteoarthritis onset, which, if we better understood, could help us to understand who's at the greatest risk of developing osteoarthritis, so who should we target, and then help us to decide what we should be doing with those people. How do we develop, evaluate, and implement secondary prevention interventions? So keeping that in mind, we initiated the Alberta Youth Prevention of Early OA, or Pre-OA study at the University of Calgary in 2012 at the Sport Injury Prevention Research Centre. Basically, this study is an ongoing longitudinal cohort study. It involves 200 participants, 100 that sustained a sport-related interarticular knee injury 3 to 10 years previously when they were under the age of 18, and then 100 controls that are matched on age, sex, and sport. And basically what we're doing is following them annually on a diversity of outcomes for 3 years in an attempt to unpack this period between joint injury to disease onset to have a better understanding of what's going on. So the aim of the study is really to determine if individuals that have had a history of youth sport-related knee injury differ from healthy match controls on a variety of structural, physiological, clinical, functional, and behavioral outcomes. And we have one primary outcome in each one of those categories. However, given the uniqueness of the study, the opportunity to consider other outcomes to inform future studies was too good to pass up. So we've also included additional outcomes in each one of these categories related to activity, injury, and osteoarthritis. So just to give you a little bit more of an idea about this cohort, 55% of the participants are female, and at the entry to the cohort, the participants had a median age of about 22 years. In the injury group, the median age of injury is 16, but we have individuals who sustained their knee injury as young as 9 and then as old as 18. The median time between injury and follow-up 1, which is what I'll be talking about today, was approximately 7 years, and then 63 of the 100 injured participants had undergone surgery for their knee. Just to give you a bit more of a breakdown of the injured group, 54 of them had third-degree anterior cruciate ligament tears, and as is standard practice in Canada for youth ACL tears, all of these were reconstructed. 15 had isolated meniscal injuries, 7 of which had arthroscopic surgeries. 13 had other ligamentous injuries, so this is either first to third degree medial collateral or lateral collateral sprain, or first to second degree anterior or posterior cruciate ligament sprain. 1 had a fracture, and then the remaining 17 had either dislocated or subluxed their patella. All of the participants in the study have undergone bilateral MRI series, and these studies have been rated by a radiologist blinded to study group using the MRI Osteoarthritis Knee Score, or MOAKS. And then study personnel have applied these accepted criteria for MRI Defined Osteoarthritis to basically classify each knee as either having or not having MRI Defined OA. Based on 73 matched pairs, we see a 29% greater prevalence of MRI Defined OA in the injured group compared to the healthy controls 3 to 10 years post-injury. Keep in mind, though, that this is a structural outcome. This diagnosis of MRI Defined OA is just a structural diagnosis. If we look at the odds of MRI Defined OA based on injury type and surgery, we see that the odds of MRI Defined OA are 10 times greater in those that have had an injury than in the matched controls. Further, that these odds increase if the person has torn their anterior cruciate ligament, undergone knee surgery, or sustained an ACL tear and or a meniscal injury. We've also used the KOOS, or the Knee Injury and Osteoarthritis Outcome Score, to evaluate symptoms and function related to knee injury and osteoarthritis. This tool was designed specifically for young active participants, and there's 42 questions that are divided into 5 subscales. A comparison of within-pair differences across the 5 subscales reveals that injured participants score lower, indicating a poorer outcome on all the 5 subscales, with the largest between-group differences being seen in the knee-related symptoms and knee-related quality of life subscales. We've also used the Godin Leisure Time Questionnaire to estimate physical activity. This questionnaire is valid and reliable for measuring mild, moderate, and strenuous physical activity over a typical 7-day period. And although we've seen no between-group differences for the total metabolic equivalence from this questionnaire, if we take all the participants in the study and then we separate them based on whether or not they fall into the lowest quartile for physical activity or not, we see that the injured participants are 2 times more likely to be in this lowest quartile for physical activity compared to matched controls, suggesting that they're less active. To have a better understanding of changes in body composition, all the participants have undergone dual X-ray absorptiometry or DEXA scans. Again, by comparing within pair differences, we see that the injured participants demonstrate a higher body mass index, a higher fat mass index, and have greater abdominal fat than matched controls. Further, injured participants were about 2.5 times more likely to be rated as overweight or obese by BMI, 4.5 times more likely to be in the upper quartile for fat mass index, and almost 6 times more likely to be in the upper quartile for abdominal fat compared to the healthy controls. As expected, the injured participants also demonstrated weaker knee extensor strength compared to the healthy controls, as well as weaker knee flexors. And we have not identified, though, any differences with respect to hip abduction or hip adduction strength. And then finally, we've also considered some common movement screening tests, the triple single leg hop and 2 balance tests. And what we see is that those with a history of injury have more difficult time hopping and balancing on their injured leg compared to healthy controls. So just to summarize some of these findings, young adults around the age of 22 who sustained a knee injury around the age of 16 are at a higher risk of MRI Defined OA. They have more knee-related symptoms, which impacts their activities of daily living, sport and recreation, and knee-related quality of life. They have greater adiposity. They're at a higher risk of being rated overweight or obese. They have weaker knee muscles, poorer balance, poorer physical performance, and they're less active than age, sex, and sport match controls. So going into this study, we knew that joint injury could obviously lead to osteoarthritis, but it appears that even within this first 10 years post-injury, there's an increased risk of adiposity and reduced strength, reduced physical activity and physical function, all of which have been shown to either be risk factors for or associated with obesity. Now, although the onset and the causes of osteoarthritis are complex, the 2 most established risk factors for osteoarthritis are previous joint injury and obesity. So the story that appears to be emerging is that instead of just having one known risk factor for osteoarthritis, previous joint injury, youth with a history of sport-related knee injury seem to be heading down a road where they're going to acquire a second risk factor, obesity, that's not only going to accelerate the rate at which they progress to the disease, but may very well accelerate the rate at which the disease itself progresses once they actually have osteoarthritis. So the Pre-OA study has added to the evidence base around who's at highest risk of osteoarthritis post-injury, namely individuals that have torn their anterior cruciate ligament or damaged their meniscus, who undergo knee surgery, who have a higher BMI, and who are physically inactive. We knew a lot of this before. I don't think this is particularly new. With that being said, I do think that previous studies have just looked at people with ACL tears and meniscal injuries, and the novel piece that we've included are people without those injuries to see if they progress to the disease as well. And then I think that adding, the other piece that's been added is this piece around, yes, a higher BMI or adiposity and physical inactivity are a problem. The study has also started to inform what our secondary prevention strategies should look like. They need to address these modifiable risk factors, such as an increase in adiposity, physical inactivity, and muscle weakness, and really facilitate recommended levels of physical activity and long-term musculoskeletal health versus just solely being focused on returning to sport. This is obviously going to be accomplished in a variety of different ways and approaches. If somebody has hurt their knee and they require surgery, we know that there's good evidence to suggest that prehabilitation or rehabilitation prior to the surgery increases the positive outcomes post-surgery. If they don't require surgery, they're going to need rehabilitation. A big piece of that is going to be education, as well as sport modification. And then we're likely also going to have to consider the need for maintenance sessions throughout the period after they've returned to physical activity, because we see the onset of these modifiable risk factors down the road. With that being said, though, I think a key consideration when it comes to treating these kids is that despite them believing that their knee is going to be normal post-surgery, so I'm mostly just talking about now those who've had an ACL tear, and they also believe that they're going to be able to return to sport and then they're not at a higher risk for osteoarthritis, the reality of it is that many of them will not return to their pre-injury sport or to competitive sport for that matter. Many will re-injure their ACL or have further surgery. Therefore, any secondary prevention strategies that are going to successfully address any of these modifiable risk factors for osteoarthritis are going to have to likely include setting realistic beliefs and expectations regarding return to sport and future osteoarthritis risk, as well as recognize and support the ongoing evolution of these individuals' athletic identity, particularly if activity modification is required, so that they don't become physically inactive out of frustration and depression that they can't compete in sport at the same level that they could prior to their injury. So yes, the Pre-OA study has started to inform who we should target and what we should do to potentially slow down the onset of post-traumatic osteoarthritis after a youth knee injury. But keep in mind that it's also shown that many of these modifiable risk factors are already present at 3 years post-injury, suggesting that we need to have a better understanding of the onset and the progression of these factors prior to 3 years post-injury, so as to optimize that sort of acute to return to physical activity phase. So there's still a lot of work that needs to be done to understand how to best prevent knee osteoarthritis. So just to summarize my key points, first of all, as far as primary prevention programs go, we know they work. What we've got to do is we've got to work together with all of our stakeholders to figure out how to implement them in real-world situations so that they can have an impact on the number of injuries occurring. Yes, there are consequences to youth knee injury, and in fact, as early as 3 to 10 years, we can see things like increased risk of MRI Defined OA, more knee symptoms, increase in adiposity, reduced physical activity, and reduced strength. Who do we need to target after an injury to try to minimize the onset of osteoarthritis? It's likely going to be youth who sustained an ACL tear and or hurt their meniscus, who've had knee surgery, who are at a higher BMI or at a reduced physical activity level. And then what are we going to try to do? What are we going to intervene with our secondary prevention programs? Likely these programs are going to have to focus on realistic expectations, assist in this identity evolution, promote a healthy weight and recommended physical activity, as well as address obviously any strength and functional movement deficits. Basically, what we've got to do, I think, with these kids after they hurt their knee is not just have this short-term goal of return to sport. It's obviously extremely important, and it probably will have some determining factor as to whether they remain physically active. But I think we also have to have this longer-term goal of trying to ensure that they have lifelong musculoskeletal health that's going to sustain recommended levels of physical activity. So I'm just going to finish by acknowledging the small army of individuals that have contributed to the success of the Pre-OA study, including my co-PI, Carolyn Emery from the University of Calgary, and then all of the support that I also receive at the University of Alberta from the Department of Physical Therapy and the Glen Sather Sports Medicine Clinic. And I'd be happy to answer any questions.
Thank you so much, Dr. Whittaker. That's really very interesting and some alarming statistics, I think, certainly, in how soon after an injury you can start to see some evidence of some indicators that OA is a possibility in the future. You know, when you think about the youth athletes and only 3 years out from an injury, we're seeing OA in so many younger populations now. So really something to be mindful of. So as we wait for some questions to come in, don't forget that you can chat your questions in the chat pod down there. And we are a few minutes out from our 30 minutes. So for those who do have to slip away at the 30 minutes, don't forget to check out our website and YouTube channel for this presentation. We'll be posting that in the next few days if you wanted to share with any of your colleagues. another thing I wanted to point out, we've got at the OA Action Alliance, we're doing some similar work. This really speaks to me today because we're doing some similar work with our injury prevention task group and taking some of the findings that you showed us today and the meta-analyses that you did with Dr. Emery and your colleagues about neuromuscular prevention training programs, and we've kind of come to the same conclusion that these are great programs. It's just, getting the word out and getting coaches to take up these programs when so many coaches, may have their own set ways or their own tried and true methods of coaching. It's hard sometimes to get them to change without the right information. So I think that's a key point.
Yeah, I think so too. And I think actually what's really interesting is a colleague of mine by the name of Carly McKay. She's over at Bath University in the UK. She's a sports psychologist. She's from a sports psychology background. And what she started to do is unpack sort of why these programs aren't being implemented. And what kind of preliminary findings we're finding is that it really comes down to the coach's self-efficacy to deliver the program. It's not that they don't believe that they won't work. I think they understand that they'll work, but they're not sure that they can actually deliver them in a way that's going to reduce injury. And then it's also some of those barriers you're speaking about with respect to sort of just field time and location. And, there's only so many minutes for a practice. And do I really want to spend that time doing these programs? And how do I fit it into sort of my traditional approach to delivering a practice and a game? But I think there is some work being done that will actually really help us figure out, how do we work with coaches and athletes to really get these programs, to get the uptake there. And it looks like the coaching seminars are a way to go, but we've just got to make sure we're delivering them in a way and with the content that actually is going to help them then be able to deliver the program in that real world context.
Yeah, I agree. I made a note of those coaching seminars. I thought that's a potential good avenue to go. We do have a question that came in. Do you have any information on how this might relate to people with bleeding disorders such as hemophilia whose joint bleeds are similar to sports injuries?
Ruth, thanks for the question. I don't. I mean, hemophilia is just not an area that I've spent a lot of time with, but I suspect, obviously my understanding is we also get, degradation of the joint surfaces and the joint itself when there's been a repeated number of bleeds in the joint. Whether the mechanisms are the same, I don't know. I would be shocked to think that, a joint injury and then that being compounded by an increase in adiposity and a reduction in physical activity wouldn't contribute to that progression also in this sort of a situation as opposed to just pure OA. And I think the key thing about the adiposity is that it's not just the increase in load to the joint, but obesity is associated with a lot of this microinflammation, which drives that inflammatory piece drives the degradation of the cartilage, and I suspect that that's something that's seen as well as in hemophilia. And I would think to some degree this model of you've had the joint injury, and because of that now, not only do you end up with more degradation of the joint, but you actually have these kind of onset of additional modifiable risk factors. My guess is they may be similar in that population, but it would be interesting to see if there's any literature or anyone who's looking at it.
Great, thank you. We have another question. I'm wondering whether knee OA is further differentiated, for example, TF versus PF, and I'll let you translate that, and whether there are different risk factors for these. For example, is patellar dislocation or pain associated with increased risk for PF OA?
Yeah, it's a really great question, Gretchen, and we have that data. We haven't completely, drilled it down yet. I will tell you that when we look at the compartment that the MRI Defined OA is in, so the structural changes, we see it mostly in the medial compartment, not really shocking, of the tibial-femoral joint, but we see a good chunk of it in the patellofemoral joint as well. We have not gone back yet to see if those that are exhibiting it in the patellofemoral joint are the ones that belong to that category of patellofemoral subluxation or dislocation. It's possible. I think it's definitely a hypothesis to consider. But it's really interesting because there's some nice work that's been done out of Sweden and Denmark and Australia with Kay Crosley's group and Michael Rathleff that have looked at just the high incidence of patellofemoral joint osteoarthritis after ACL reconstruction. and making some suggestions and links there to changes that occur after that joint injury and or surgery that predispose the patellofemoral joint to more changes than actually the tibial-femoral joint. But it's a great question, and I think it's something that we will definitely look at, but I don't know the answer quite yet. But I think there's a possibility for sure that you know, we might see that link.
Thank you so much. As we wait for any additional questions to come in, good discussion today. I think this is such an important issue. As people are thinking about their questions and as we start to wrap up here, just a note for our next webinar on October 19th about the National Agribility Project and Arthritis Foundation Partnership for those who live and work in rural environments. But back to our presentation today, I wanted to thank you very much, Dr. Whittaker. Just really interesting work, and very much appreciate you joining us and sharing that with us today. Thank you.
Sure, no problem. And if anyone's got any questions later that come up, I've included in my Twitter handle there, the jwhittack_physio. If you want to tweet me or send me a message, no problem. I'd be happy to answer.
Fantastic. Thank you. Thanks, everyone, for joining us today.
Okay, thank you.